All right, so cardiac rehab. If you do not remember things like your flow of blood through the heart or the anatomy of the heart, where your valves are located, any of those things from pathology, I would go back and review it to help supplement this lecture. um, but cardiac rehab is a couple of different things when we think about it in the context of physical therapy. So there is a section of the medical world called cardiac rehab where they're typically exercise physiologists working with patients following cardiac interventions to exercise them back to normal or prior aerobic conditioning. And that arena typically doesn't have a lot of PTs or PTAs. You might have one evaluating PT as part of the team, or they might operate under a PA. There's not a clear place for PTs and PTAs in cardiac rehab, and that's not to say that they don't exist there. It's just not to say that it's the number one arena. But you can also think of cardiac rehab in the context of physical therapy as physical therapy treatment of patients with cardiac conditions. And so, whether that is preventative or in response to a cardiac condition or cardiac event, we will work with these patients, and it's important to know different things about their health status, be able to take different assessments, be able to determine different information from reading an EKG. And so we are going to cover a lot of different aspects in this lecture. It will be a longer one than your previous ones, so take your time with it, break it up as you need to, and ask questions. So heart disease, we're going to go with a couple different definitions here, starting with CVD, or cardiovascular disease, and that is the pathological process of atherosclerosis affecting the entire arterial circulation, which contrasts with CAD, which is coronary artery disease, is the process of atherosclerosis of the coronary arteries. So CVD is going to affect the whole body circulation. CAD is going to affect blood flow to the heart, so the heart muscles blood flow. CAD includes diagnoses of angina pectoris, myocardial infarction, silent myocardial ischemia, and sudden cardiac death. CVD may be caused by atherosclerosis, altered myocardial muscle mechanics, valvular dysfunction, arrhythmias, and hypertension. So atherosclerosis is a lipid-laden plaque that adheres to the inner lumen of arteries, causing a decrease in the inner diameter of the vessels. Heart failure is impaired left ventricular dysfunction, or CHF, congestive heart failure, and may be caused by myocardial scarring from an MI, cardiomyopathies, or impaired valve function. So we see a lot of overlap with these different diagnoses and definitions, and oftentimes that is true with patient charts as well. You will see multiple of these comorbidities listed. CVD is the leading cause of death and disability in the United Nations. CAD is the most common type of heart disease, and CAD is the number one killer of women, taking more lives than all forms of cancer combined. Cardiac arrhythmias are something that we can experience or see in patients in cardiac rehab, and so understanding what a cardiac arrhythmia is and how to recognize it on an EKG and what to do in response. So arrhythmias are caused by a disturbance in the electrical activity of the heart, which disrupts conduction of impulses, which cause contraction of the myocardium. So our heart is a muscle that operates off of electrical impulse, and that electrical impulse stimulates different parts of the heart to contract at the appropriate time for adequate blood supply to the entire body. But if that electrical system is disrupted, we'll have cardiac arrhythmias. Those can be benign or malignant. Malignant would be life-threatening, benign would be non-life-threatening. Examples of malignant arrhythmias would be ventricular tachycardia and ventricular fibrillation, which you can see in the picture on the far left is ventricular tachycardia. You might also see clearer QRS complexes in ventricular tachycardia, but the point is you have a whole heart contraction, so that full wave, but at a faster interval than a normal sinus rhythm. Ventricular fibrillation will be that middle picture, and that's where you see not quite as whole heart contractions because the ventricles are fibrillating. They're not contracting, but they're spasming essentially. And so this also is a malignant arrhythmia. And then atrial fibrillation is a benign arrhythmia that many patients will experience, but can put them at greater risk for things like stroke because of the disruption of blood clots or plaques. And we can see AFib in this last strip here, where you have normal QRS complexes, which represents the ventricular depolarization, but you have abnormal P waves, and so you see the fibrillation of the atria through those sporadic P waves leading up to your QRS complexes. So looking at where our heart lies, it is in the left thoracic cavity. I hate that the base is the top, but the base of the heart is the superior end located between the second and third ribs, and then the apex, which is the inferior end, is located at the level of the fifth rib. It's rotated slightly so that the right ventricle lies more anterior to the left ventricle, and it's tipped slightly so that the apex is more anterior and closer to the chest wall. The right atrium is located in the area of the second intercostal space and the angle of Louis, which is where your manubrium meets your sternum, and you can palpate that on yourself and then drop off to the second intercostal space, and that would be the location of your right atrium. Continuing on with the anatomy of the heart, we look at the heart tissue. The pericardium is the outermost layer of the heart tissue. And there's two layers of the pericardium. There's an outer tough fibrous layer, which is known as the parietal pericardium, and an inner thin visceral layer. And so those two layers cover each of their respective walls. The inner layer covering the viscera of the heart, and the outer layer attaching to the chest wall. There's pericardial fluid that runs between those two layers that acts as a lubricant, but pericardial rub is what happens when that lubricant is no longer sufficient and can cause heart murmurs or chest pain. Inflammation of the pericardium is called pericarditis, and clinical signs include a pericardial friction rub, like we talked about, or audible rating sound suggesting irritation of the pericardium, and that's something that you would hear upon auscultation, and we will practice that skill in the lab. The myocardium makes up the muscular wall of the heart, and dysfunction of the myocardium are called cardiomyopathies, and they can be dilated, hypertrophic, or restrictive in nature, and the cause is, or the type is associated with what changes happen to the myocardium. So a dilated myocardium is going to have dilated ventricles, and this can often result from alcohol abuse or be caused by myocarditis. Hypertrophic hypertrophic cardiomyopathy is going to be where you have thickening of the ventricular walls, and so that's going to decrease the amount of blood that the ventricles can hold because muscle is taking up the space that the ventricles are supposed to have to hold blood. And restrictive cardiomyopathy is going to be where there's stiffening of the wall. And so the changes in the muscular tissue are what define the different types of cardiomyopathies. The endocardium is the inner lining of the heart, which is continuous with the valve tissue and the endothelium of the blood vessels. And patients who get endocarditis are at risk for developing vegetations on the valves that can dislodge and become emboli, which can then lodge in the vessels of the heart or travel to the brain and cause CVAs. So going into the cardiomyopathies, we talked about these, but this just highlights them a little bit different, or a little bit more dilated. We've got dilated ventricles and altered contractile function of the heart. So CAD is the primary cause of this type of heart failure, but we've talked about myocarditis and alcohol abuse can also cause it. Hypertrophic cardiomyopathy has altered ventricular filling and an increase in ventricular mass because there's that thickening of the muscle. The walls of the myocardium become thick and decrease the size of the inner chamber. Chronic hypertension and aortic stenosis can cause this type. It's basically hypertrophying of the heart muscle, and so when there's an increased pressure that the heart has to overcome to pump out blood out to the body, that will happen as a result of that hypertension. The muscle is then going to thicken hypertrophying to get stronger to overcome that pressure. And then restrictive cardiomyopathy, there's limited filling ability owing to the presence of a rigid ventricular wall. So the connective tissue stiffens, and this often happens with diabetes, but the ventricles don't empty out when the heart contracts because of the stiff walls, and so they can't fill because there's already blood in there. Coronary blood flow we talked about is the blood flow to the actual heart of the muscle, and so this is what keeps the heart oxygenated and alive. And reduced blood flow within the coronary arteries will result in ischemia and possible infarction of the cardiac tissue or coronary artery spasm. Cigarette smoking is a major risk factor for vasospastic angina, which angina being chest pain. But these highlighted here are our main arteries to the heart. Patients with cardiopulmonary disease commonly present with nonspecific signs and symptoms of dyspnea and fatigue, and so we see a lot of overlap between our valvular heart disease and our cardiomyopathies in symptom presentation. And the cause of these symptoms may be from any number of things, including valvular dysfunction, or we can have decreased muscle contraction from any of our cardiomyopathies. And so looking at those, where those things overlap the most, we've got this visual here. And so on the right are cardiomyopathies, and those things typically are going to be influenced by genetic factors, inflammation, radiation, chamber remodeling, intracellular storage, and extracellular amyloid infiltration. Not as worried about you guys knowing those implicating factors so much as where we have overlap in their presentation. So valvular heart disease and cardiomyopathy coexist together in dilated cardiomyopathies and in hypertrophic cardiomyopathy. We'll see valvular heart disease with possible concomitant myocardial involvement in mitral valve prolapse and bicuspid aortic valve dysfunction. Cardiomyopathy with possible concomitant valvular involvements will be seen with cardiac amyloidosis, whatever that one is, Fabry disease, and Raynaudopathy. So cardiac amyloidosis is going to be your primary one for you guys to be able to identify on that. And then acquired disease causing valvular heart disease and cardiomyopathy is going to happen with autoimmune disorders and radiation-induced cardiac damage. And that's going to typically be more of our restrictive cardiomyopathies. So the whole point of the heart is to provide adequate cardiac output to give enough oxygen to meet the metabolic demands of all the body's tissues. So whatever activity you're doing, whatever oxygen demand your tissues have as a result of that activity, the goal of your heart is to pump enough blood out to reach that oxygen demand. Our cardiac output must be able to adjust and adapt to the body's changing needs. For example, you need more oxygen when you're sprinting than you do when you're sleeping, and so it wouldn't make sense for your heart to constantly pump out the amount of blood you need at the rate you need it for sprinting as at the time when you are sleeping. Our cardiac output is defined as the amount of blood leaving the ventricles per minute, and so it's a rate that's expressed in liters per minute. Normally, at rest, we have a cardiac output of 4 to 5 liters per minute. And we calculate that based on our heart rate times our stroke volume. So however much blood is leaving the ventricle in our stroke volume every beat times how many beats per minute is going to give us our liters per minute cardiac output. So our stroke volume, like we said, is the volume of blood ejected with each ventricular contraction, and it's influenced by 3 factors: our preload, our contractility, and our afterload. So preload is the amount of blood filled in the ventricle at the end of diastole, which is the left ventricular end diastolic volume. So how much blood fills up into the ventricle at the end of diastole before systole when we get a ventricular contraction. And so that preload is how much blood is loading up in the ventricle, getting ready to eject out of the body, or out of the heart. Then we look at our contractility, and it's the ability of the ventricle to contract forcefully. And so innervation of the heart, muscular strength of the heart, thickness and responsiveness of the walls of the heart are all going to influence contractility, but basically how much power does that heart have to contract once it's ready to. And then our afterload is the force that the left ventricle must generate during systole to overcome the aortic pressure and open the aortic valve. So our blood pressure in our body is pushing back onto our aortic valve, and the heart has to contract hard enough to push the blood out, overcoming that pressure from the body. And so our afterload is influenced by what our peripheral blood pressure is like. And so when we have hypertension, we have a higher afterload. And so those three factors contribute to how much blood can actually leave the ventricle when it contracts. And that is what our stroke volume is. Even in healthy individuals, the heart doesn't eject 100% of the blood from the ventricles each time it contracts. And so we're never going to see 100% ejection fraction, which ejection fraction is the percent of blood from preload that is actually ejected. How much do we get out into the body? A normal ejection fraction is going to be somewhere between 55 to 75%, and it's used to measure the heart's contractility. When patients are experiencing heart failure, you will often see their ejection fraction noted in the chart, and that will help you understand their body's responsiveness to exercise, because if they have a diminished ejection fraction, that means they're going to have a diminished stroke volume. And the only way to compensate for cardiac output when they have a diminished stroke volume is to increase heart rate. And so you might see an excessive increase in heart rate in order to reach the cardiac output demands when there's a diminished ejection fraction, or if the patient's on medication to limit that response, you might see a decreased activity tolerance because they're unable to reach the cardiac demands of higher level functions. The cardiac cycle consists of two phases, systole and diastole. So systole is the contraction phase and diastole is the filling phase. And when we talk about this, we're talking about the ventricular contraction phase and the ventricular filling phase. The atria follows some of the same cycle, but it gets confusing if you try to reference both. So let's look at the ventricular contraction as systole and the ventricular filling as diastole. The first 2/3 of diastole is passive, and the last 1/3 is active, and that's when the atria contract and push blood into the ventricles, and this is known as the atrial kick. Systole begins with both the AV and semilunar valves closed, and there's an isovolumetric contraction that increases pressure within the ventricles until the semilunar valves open, and then the left ventricle concentrically contracts, causing blood to be ejected. So basically, there's this little contraction to maintain the same volume of blood, and then we get a full forceful contraction to push that volume of blood out into the body. After the blood is ejected, the aortic valve closes and systole is complete. And those are your two phases of the cardiac cycle. So as clinicians, we will assess the cardiac cycle by auscultating or listening to heart sounds. And the normal heart sounds are S1 and S2, and that's that lub-dub that you think of when you're listening to a heartbeat. And these heart sounds are associated with the valve closing. So S1 is associated with atrioventricular valve closure, and S2 is associated with semilunar valve closure. So systole happens between S1 and S2, and diastole occurs between S2 and S1. So if my atria valves are closing at S1, S2 is then when my ventricular valves are closing. And additional sounds between S1 and S2 or between S2 and S1 are going to be identified as S3 or S4, and we would call those abnormal sounds. But our normal heart sounds are S1 and S2, systole being between S1 and S2, diastole being between S2 and S1. We don't have conscious control over our heart, and so it has to be regulated by some part of our central nervous system, and that comes from our autonomic nervous system. We have a neurohormonal influence regulating our heart's function, and so our autonomic nervous system influences the heart and blood vessels through both the sympathetic and parasympathetic nervous system, depending on what the body's demands are at the moment. So the sympathetic receptors of the heart are beta adrenergic receptors, and they're located within the sinus node and myocardium. And so we can try to remember that by knowing that a lot of patients who have cardiac dysfunction are on beta blockers, because those cardiac meds serve to block those receptors that would increase heart rate. Stimulation of these receptors through the release of norepinephrine increases heart stimulation and causes an increase in heart rate, an increase in contractility, an increase in coronary artery dilation. And sympathetic stimulation in peripheral vessels causes vasoconstriction and increased peripheral vascular resistance. So, looking at what happens to the heart versus the periphery with the sympathetic nervous system, we've got an increased heart rate so that we're putting more blood out into the body, increased contractility, so that way, again, putting more heart out into the body, or blood out into the body. And then increased coronary artery dilation means that the blood, or the heart itself, is going to get more oxygen because there's going to be more blood flow to the heart muscle itself. But in the periphery, we see vasoconstriction of our peripheral vessels, meaning that there's less blood flow going to the periphery, and an increase in blood pressure with that increased peripheral vascular resistance. Epinephrine is released during exercise, which causes an increase in heart rate and an increase in contractility, which is important to us because we want those things to help increase cardiac output when we have increased oxygen demands. The parasympathetic system influences the heart through the vagus nerve, and parasympathetic stimulation causes a decreased heart rate, decreased atrial contraction force, so that atrial kick is going to be decreased, and then a decreased conduction speed of the AV node, so that's going to contributing to slowing of the heart rate as well. Drugs that mimic actions of the sympathetic nervous system are called sympathomimetics, and those are dopamine, atropine, epinephrine, and those that suppress the sympathetic nervous system are called I don't know how to say that. Sympatholytics. Never in my life have I had to say that word, so I apologize. But those are going to be your beta blockers and your beta adrenergic antagonists, which stop activation of the sympathetic nervous system. And that's how a lot of cardiac meds work, is that they block a receptor that increases the body's natural response to an increased oxygen demand, which inhibits our abilities for exercise but protects the heart tissue itself. And so that's a balance that we have to strike with our patients, is pushing them to the appropriate level that their heart is capable of responding for their body's demands, but not pushing them so far that we are creating a deficit of oxygen. Electrocardiograms will be abbreviated as ECG or EKG. And we talked about our cardiac arrhythmias, and those strips that we used are going to be our EKG strips that help to identify those cardiac arrhythmias. And so basically an EKG is the monitoring of the electrical activity of the heart. The EKG complex reflects the phases of the conduction pathway. So a normal EKG has a P wave that depicts the sinus node and atrial depolarization, followed by a PR segment, which is going to be between our P wave and our QRS complex. And that's going to demonstrate the conduction through the AV node, where the electrical signal will travel from the atria down to the ventricles. Our QRS complex denotes the electrical flow through the ventricles and ventricular depolarization. Our ST segment describes the initiation of ventricular repolarization. So basically, our heart signal has to get charged up, send through our atrium, through our AV nodes, through our ventricle, and then it has to recharge. And then the T wave illustrates the completion of ventricular repolarization. Each EKG complex represents one cardiac cycle or one heartbeat, and so we can determine beats per minute by looking at an EKG strip as well. There's not a whole lot of areas where you are clinically going to apply EKGs, but I can tell you that they have shown up on the licensure exam multiple times, partially because they're an easy graphic question, and so I would familiarize yourself with some of those abnormal EKGs that were in the PowerPoint earlier. Looking at a normal sinus rhythm EKG, so here is our P wave where we have atrial depolarization. Our PR interval is running from the start of our P wave to the start of our QRS complex. Our QRS complex is ventricular depolarization. Our QT interval is going to run from the start of our QRS complex to the end of our T wave. And so we see where we have this depolarization and it goes down below the level it was essentially charged to, and then it has to progressively work its way back up. We've got this repolarization phase where then things will stabilize. In patients who are experiencing an MI, you might see changes to the ST segment or the inversion of the QRS complex. And so if you have a patient who you are treating on a telemetry unit where they are actively being monitored with EKG and you notice a change where this is higher, this section here, or the section between S and T is higher, or you notice an inversion of your QRS complex, it's important to stop your exercise, notify the medical team, all of those things. So here we can look at some examples of some of those changes. But an EKG is used to monitor heart rate, rhythm, conduction delays, and coronary perfusion. We can get a lot of information from an EKG, and they can be set up as a single lead, a 3-lead, or a 12-lead. And that basically just means how many different ways receptors we're putting on the body to read around the heart. If ischemia is present, the ST segment will be depressed and the T wave may be inverted. We also talked about that QRS complex being inverted as potential as well. With a large acute MIs, there will be ST segment elevations. And so this graphic here shows you the progression of an MI to where we're going to see hyperacute T waves minutes to hours after the initiation of an MI, and this is where you see that inverted QRS complex. 0 to 12 hours following an MI, we have the QRS complex pointed the right direction, but now we have this ST elevation where we never drop back below our baseline during that repolarization phase. 1 to 12 hours following an ischemic infarct, we'll see a Q wave developing, and then ST elevation with a T wave inversion 2 to 5 days after an MI. And so a patient's EKG is going to evolve as the process of their MI, especially if there's not medical intervention. Much like the body has oxygen demands, the heart itself has oxygen demands, and so our myocardial oxygen demand is known as MVO2, and that is the energy cost to the myocardium, which is the heart tissue, heart muscle itself, right? So MVO2 is calculated as the product of heart rate and systolic blood pressure, and it's also known as the rate pressure product. So if we take our heart rate and we multiply it by our systolic blood pressure, that's going to be our rate pressure product, or our myocardial oxygen demand. And any activity that increases heart rate and or increases blood pressure is going to increase MVO2, because if heart rate times blood pressure is MVO2, increase in one is going to increase the outcome, right? During exercise, coronary blood flow may increase up to 5 times normal to meet the body's demands, and so our MVO2 can increase pretty drastically. So cardiac patients are typically going to have their lab values monitored more closely when they're in the acute care setting, but it's important to familiarize ourselves with these lab values, especially for purposes of identifying contraindications to treatment or precautions to treatment. So hemoglobin, we want to know 12 to 14 grams per 100 milliliters in male and 14 to 16 grams per 100 milliliters in females. Truthfully, don't worry so much about the units, know what your values are. So 12 to 14 in males, 14 to 16 in females is normal. If we have a patient with lower hemoglobin levels, the heart must work harder because there's reduced oxygen carrying capacity. So if hemoglobin carries oxygen to the heart and the rest of the body, and there is less of it in the blood, then there's less oxygen getting to all of the tissues. And so the heart has to make up for that by increasing heart rate so that overall cardiac output is increased. Our general rule of thumb is use caution and lower exercise intensities when working or exercising patients with hemoglobin levels less than 8 grams per 100 milliliters. Though I will tell you that most hospitals have a transfusion protocol at 7, and so somewhere check with your facility, you're going to have a hold order in place for that patient for therapy because of hemoglobin levels if they are below 8. Electrolyte levels. We can look at several different electrolytes, but ones that we're going to look at specific to the heart are going to be potassium, calcium, and magnesium. And all of these influence the electrical conductivity of the heart. And so that's why they are important to monitor and be safe with our patients. And so if we have a patient with hypokalemia, which is low potassium, we can have them be at risk for arrhythmias, flattened T waves, and depressed ST segments, and they may also experience leg cramping. Hyperkalemia is also a cardiac risk factor, and so we want to make sure that we're paying attention to that 3.5 to 5.5 range, and those will be on a slide coming up here, and making sure our patients within those. But hypokalemia is a bigger risk for arrhythmias. Hypocalcemia is going to be where we have decreased calcium in the blood, and this causes reduced cardiac contractility, so the heart isn't going to contract as strongly. And ventricular ectopy, which is an ectopic beat, meaning that there's a signal causing the ventricle to try to contract before the one that's timed for it. And so it's this abnormal beat that's being sent from somewhere that isn't in the normal pathway. And then hypomagnesium is going to be low magnesium, and this can also cause ventricular ectopies. Our BUN and creatinine levels are important to watch for patients in heart failure who are taking diuretics. Diuretics can be used to manage heart rate, but they also are going to influence kidney function because they influence how much fluid the body retains versus gets rid of. And so our normal BUN is going to be 10 to 20, and our normal creatinine is going to be 0.6 to 1.2. Blood glucose is important to monitor because many patients with heart disease also have diabetes, and so normal is 70 to 100. We want to make sure that we are paying attention to when we implement exercise in relation to when a person has received their insulin and when they have eaten, to ensure that we do not let their blood glucose drop too low with the effects of exercise. But we also want to monitor for elevated blood glucose, as that can cause patient issues as well. So these are our normal lab values, looking at sodium from 135 to 145, potassium 3.5 to 5, chloride 95 to 105, calcium should be 9 to 11, BUN 10 to 20, creatinine 0.6 to 1.2. I think that's a typo there, but 0.6 to 1.2. Glucose 70 to 100 or 110. There's different textbooks, and I've checked with both your board's resources, but you won't be wrong with knowing either range. Your carbon dioxide is 20 to 29, magnesium 1.5 to 2.5, hemoglobin in females 12 to 16, adult males 13 to 18, and hematocrit 36 to 46 for females, 37 to 49 for males. I would say 12 to 14 and 14 to 16 from that previous slide are probably a little bit lower than what your boards are going to reference, and so I would take your lab values from this slide for understanding them. Hemoglobin is going to be an important one to know, BUN and creatinine are going to be important to know, and potassium are going to be important to know. Maximal oxygen consumption and VO2 max, you guys talked about this when you went over aerobic exercise in Therex 1, but it reflects the maximum amount of oxygen consumed per minute when the individual has reached a maximum effort. And so we use VO2 max to talk about METs and metabolic equivalents. We're going to touch on this because it's in the textbook, but I have not found reference to it for anywhere on your licensure stuff, and so I think it causes too much potential for confusion given its limited use in the clinic. But A metabolic equivalent is a unit of measure of energy expenditure or work, and a single met is defined as the amount of oxygen consumed at rest per unit of body weight for 1 minute. So if we are prescribing exercise based off of METs, less than 3 METs would be having the patient work at a light intensity, 3 to 6 METs would be working at a moderate intensity, and greater than 6 METs would be a vigorous intensity. Under normal conditions, with aerobic exercise, we should see an increase in heart rate that is linear with increasing workloads. Our oxygen uptake increases with workload. Our systolic blood pressure increases linearly with increasing workloads. Our diastolic blood pressure should increase slightly, but then otherwise stay about the same. We will experience an increased body temperature with workload and an increased respiratory rate with increased workload. So if those are normal responses, then we have to be aware of what abnormal responses are too. And when we see abnormal responses, we have to know how, as clinicians, to respond. And typically, we're going to either reduce the intensity of exercise or stop the exercise and assess our vitals, depending on how severe the abnormal response is. And sometimes there is no cut and dry for that. It's about using clinical decision making and clinical reasoning to know what risk the patient is at. And sometimes that comes with knowledge, and sometimes that comes with experience. It's important to know that when we are watching cardiac patients and we are monitoring vitals, that some medications are going to suppress the sympathetic nervous system, like we talked about earlier with the beta blockers. And so that's going to limit the body's ability to increase the heart rate. And so we won't get the linear increase in heart rate with increasing workloads that we would expect. And whether or not that is abnormal depends on whether or not the patient is on a beta blocker, because if they're on a beta blocker, then that's their normal response. And so we wouldn't necessarily terminate exercise at that point. And so again, clinical reasoning is going to come in as a play in how we manage all of these abnormal responses. And they are outlined in box 31.1 on page 480 in your Big Red textbook. But failure of systolic blood pressure to rise with exercise would be an abnormal response. A hypertension blood pressure response greater than 200 millimeters of mercury systolic or 110 millimeters of mercury diastolic, we're probably going to terminate exercise there and have the patient rest and reassess vitals if we're seeing blood pressures of those levels. If we see a progressive fall in systolic blood pressure of 10 to 15 millimeters of mercury, we're not supposed to see a decrease, and so we're going to have to go ahead and check that. A significant change in cardiac rhythm, and we can be assessing that by monitoring an EKG, or even when you check pulse, obviously we're looking at rate when we look at heart rate and we're counting pulse, but we can feel whether it is regular or irregular. And so if you're feeling consistent regular beats versus you feel it skipping a beat and there's an irregular rhythm, that's still information that we can, as therapists, can ascertain without the patient being connected to any equipment. If the patient has moderately severe or progressive angina, and we're going to talk about the angina scale and when to terminate activity, but we don't want patients exceeding a 2 out of 4 on that angina scale. And so again, we're going to use clinical judgment based on what level they're at on there. Same thing with marked dyspnea. Obviously, we have to push patients to a point where they might get somewhat short of breath or feel dyspneic, but we want to use clinical judgment. Same thing, we're going to push them to a 2 out of 4, but we're not going to let them get a 3 out of 4 on that dyspnea scale, and we'll talk about that when we get to that slide. Dizziness, lightheadedness, or ataxia, again, monitoring, giving patients rest breaks as needed, checking vitals, and seeing what needs to be done to progress from there. If we see evidence of cyanosis or pallor, those are typically signs associated with cardiac dysfunction, and so we want to assess the situation. Excessive fatigue, we have to monitor for what demands we're placing on the patient, what their oxygen demand is going to be as a result of the activities they're participating in, and what their capacity to meet that oxygen demand is. And then looking at things like leg cramps or claudication, which can indicate peripheral vascular disease, and how that affects the patient's ability to consistently, continually work, or when they need rest breaks, or how we need to manage those symptoms. Pathological conditions that may underlie or be associated with heart disease include hypertension, atherosclerosis in the coronary arteries, altered myocardial muscle mechanics, valvular dysfunctions, and arrhythmias. Common signs and symptoms associated with heart disease are chest pressure, dyspnea, fatigue, syncope, and palpitations. And these are not necessarily the clearest cut symptoms either, and they can be vague across many cardiac diagnoses, but they are common across them. Hypertension is currently the most prevalent cardiovascular disease in the United States, and we're recognizing normal blood pressure as less than 120 over less than 180. There's discrepancy between the texts, and so that's what we're going to go with when we get to the slide that discusses the levels of hypertension. We'll talk about that. So these definitions are coming from your score builders text, and so that's going to be in line with what will be for your licensure. I don't necessarily anticipate you having a boards related question over having to classify the person as what stage of hypertension. But it's important to note that stage 3 is known as a hypertensive crisis. And so we want to be able to identify when a patient is in hypertensive crisis and how exercise would be contraindicated at each one of these levels. And so pay attention to those contraindications that we talked about earlier. When we look at hypertension, we can have primary or secondary. Those can also be known as essential or non-essential. So our primary or essential hypertension is the one that has no known cause for elevated blood pressure levels. And it's typically the most common. It's idiopathic. It may be caused by genetic factors or environmental factors such as excessive alcohol consumption, increased age, lack of exercise, or glucose intolerance. And while those may seem like they're causative factors, it's that we can't connect it to any one of those to say, oh, yep, this is why you have it. And so that's what makes it primary or essential, but can be caused by those environmental things. Secondary or non-essential is caused by an identifiable problem such as primary renal disease, illicit drug use, renovascular disease, obstructive sleep apnea, Cushing syndrome, endocrine disorders. There's a specific comorbidity that we can tie to the cause of that hypertension. Uncontrolled elevated blood pressure levels put patients at risk for heart failure, renal failure, dissecting aneurysms, peripheral vascular disease, retinopathy, and stroke. And so it's very important that we pay attention to hypertension and management of hypertension and ensuring that patients are taking their medications as prescribed and in advance of therapy as needed, so that way we are not putting them at risk of any of these secondary problems as a result of hypertension. Things that we can do to help encourage patient management include DASH, which is the dietary approach to stop hypertension, which encourages patients to eat plenty of fruits and vegetables with a low-fat dairy and reduce saturated fats and total fats. They want to encourage them to limit red meats, no more than 2 drinks per day for men and 1 drink per day for women and lighter weight individuals. And by that, they're talking about alcoholic drinks. The decreased sodium intake and increased physical activity are also incorporated in DASH, but from a physical therapy standpoint, not using any specific tools. The primary things that we're going to make sure we are educating our patients on are their diet modification should include a reduced sodium intake. We definitely want to help them increase their physical activity, decrease their alcohol consumption, and maintain a normal BMI as appropriate. Because a 10 kilogram drop in body weight can result in a 5 to 20 millimeter mercury reduction in systolic blood pressure. And so that can be the difference between somebody needing to be on medication to manage their blood pressure versus being able to maintain it on their own. Exercise should have a combination of aerobic and resistance because that has the greatest potential to decrease systolic and diastolic blood pressure values, 4 to 6 millimeters per mercury for systolic and 3 millimeters of mercury for diastolic when they're utilized even if the patient doesn't experience weight loss. So just the implementation of exercise using a combination of aerobic and resistance training can cause a reduction in blood pressure that will happen with or without weight loss that can help a patient get off medication for it. So on the topic of medication, there are 6 classes of medication that exist to manage hypertension. We've talked a little bit about our beta blockers with how they blunt heart rate response. but they decrease beta sympathetic activity on the heart, so that sympathetic nervous system can't be stimulated because those receptors are being blocked, which results in a decreased heart rate and decreased contractility, which reduces the energy demand of the heart. This means that heart rate is not a reliable indicator of exercise level in patients on beta blockers, and we need to look at things like blood pressure and RPE scale. Our alpha adrenergic blockers relax the muscle tissue in the blood vessels and the prostate gland, which improves blood flow and lowers blood pressure. Um, the influence on the prostate gland isn't really influential to the cardiac muscle, but it is used as a treatment for benign prostatic hyperplasia as well as cardiac dysfunction. And so understanding the overlap between that medication application is important and why the prostate gland is noted there. Angiotensin converting enzyme inhibitors are also known as ACE inhibitors, and those are used to normalize blood pressure and reduce workload on the heart. Diuretics are used to remove fluid from the body, which may help to decrease blood pressure. Vasodilators are nitrates, or nitrates are potent vasodilators that decrease preload and afterload of the heart, thereby reducing the myocardial workload. So they don't necessarily affect contractility, but they reduce blood pressure so that there's not as much afterload for the heart to overcome, and the preload is reduced in the process because there's more blood being maintained in the periphery. And then calcium channel blockers reduce blood pressure and therefore decrease work on the heart by preventing coronary smooth muscle spasm. This slide is just a repeat, so we're going to go ahead and bounce. So acute coronary syndrome, ACS, is the new terminology for ischemic heart disease or coronary artery disease. And the hallmark sign is ischemic chest pain with increased myocardial demands. So having that angina with increased activity levels or increased demand on the heart. It's important to know for documentation purposes and for licensure purposes the synonymous use of ACS with ischemic heart disease and CAD. The decrease in oxygen supply to the heart is caused by narrowing of the lumen of the coronary arteries due to atherosclerotic lesions, so not as much blood can get through the arteries because of the plaque buildup on the coronary artery walls. Risk factors for developing the plaque include smoking, poor diet that is rich in high fat, red meat, high glycemic foods, low fiber, and increased caffeine. And those are all increased risk factors for developing atherosclerosis and therefore coronary artery disease. However, coronary artery disease symptoms, or ACS symptoms, generally don't appear until the lumen is 70% occluded. So there can be a substantial amount of plaque development before a patient is symptomatic, which means that they can be at risk for a complete occlusion, which would result in myocardial infarction and potential myocardial tissue death. Angina is that chest pain that we talked about. It's cardiac-related chest pain due to ischemia. Unstable angina is chest pain that typically occurs at rest without any obvious precipitating factors or with minimal exertion. And we don't want to exercise our patients who are demonstrating unstable angina. If they have chest pain at rest, we're going to say, hey, yeah, we're going to hold therapy today. Don't think you're appropriate. Let's write a note and document why you're not appropriate. But unstable angina is definitely going to be a contraindication. Comparing that with stable angina, which is chest pain that occurs only with exercise or activity and resolves with rest. When we have a patient experiencing stable angina, we're going to use our angina scale and not let them reach a 3 out of 4 on that scale, but we can do exercises at a safe level at a 1 or a 2 on the angina scale. With stable angina, we're going to terminate exercise and assess the heart rate and blood pressure to determine the rate pressure product if they do reach a 3 out of 4 on that scale. So we want to pay attention to what information we can document if we do work outside of our safe area. Any report of angina requires action, whether that's discontinuing the activity and addressing the patient's status or checking in with them on where they are on the angina scale to determine whether or not that's the appropriate action, notifying the supervising PT depending on the severity. But the more information that you have to be able to report to the next medical professional, the better off you're going to be. Remember that your nursing staff might be your next medical professional if they're in an acute care setting. And so having as much information as possible is going to be important because you may not have a regular line of communication with this person. When we talk about damage to the heart muscle itself, we look at injury, which represents the presence of a new acute MI. Infarction depicts an old heart attack with dead tissue that cannot be reversed. So injury is the new onset that results in an infarction. Injury can be resolved if blood flow is restored within an appropriate amount of time, but once it has become an infarction, that tissue damage cannot be reversed. Irreversible changes start to appear 20 minutes to 2 hours from the onset of myocardial ischemia. So there's a 20-minute to 2-hour window from injury becoming infarction. Angina commonly precedes an MI, and so that's an important symptom to pay attention to when we have a patient with related comorbidities, but not a cardiac diagnosis, because we may be able to help point them in the right direction to get the medical intervention they need to prevent an MI, or we may need to be able to respond with the appropriate emergency response team, whether that's in an acute care setting with a rapid response or calling 911 from an outpatient setting to respond to an MI. We need to monitor the presence of angina and whether or not it's stable or unstable, and whether or not it resolves being a very big component to that determination, to know whether or not we need to refer our patient out somewhere else for help and medical attention to prevent cardiac tissue damage. Patients having an MI describe their discomfort as a 10 out of 10 and state that it feels like an intense pressure in the chest, like an elephant sitting on the chest, but there are differences between men and women in presentation, and I believe the next slide will talk about that. They may experience pain radiating into the left arm and left jaw, as well as dizziness, lightheadedness, weakness, diaphoresis, fatigue, and weakness is really important, so weakness again. We look at those differences between men and women. Men are most commonly going to see discomfort or tingling in the arms, back, neck, jaw, or shoulder with chest pain and shortness of breath. Women are more commonly going to experience dizziness with heartburn-like feelings, cold sweats, nausea, vomiting, and unusual tiredness. Not to say that there can't be overlap of these symptoms, but it's important to recognize the difference because the majority of heart attack awareness education out there is revolved around the signs and symptoms that are more common in men and not the signs and symptoms that are more commonly present in women. We talked about the changes that happen to the EKG with a myocardial infarction in the earlier slides where we had the visuals with it. But just to review, with ischemia, we see EKG changes with a depressed ST segment and a possible inverted T wave. With an MI, there's EKG changes that have an ST segment elevation and pathological Q waves, or the inverted Q wave that we talked about. And lab values that you will see documented and monitored in a patient who are there checking for an MI will include their creatinine kinase, lactic dehydrogenase, troponin, and myoglobin, because all of those will increase with an MI. So interventions that they might utilize to help prevent an MI when a patient has acute coronary syndrome or CAD, it will include PTCA, which is a percutaneous transluminal coronary angioplasty, and that's where they'll go in and use a balloon and a collapsed stent to go into the artery that has the blockage, and they will inflate the balloon that expands the stent, and then they'll deflate the balloon and retract it and leave the stent in place to help open up that artery. Another intervention would be a CABG, which is a coronary artery bypass graft, where they use a donor vessel harvested from typically the saphenous veins in the lower extremity, sometimes the radial artery of the non-dominant upper extremity. I've never seen a patient with an internal mammary artery used, but it is a possibility. But they'll take one of those donor vessels to bypass the blocked area and reroute. So it's basically creating a detour for blood flow in the heart. Sternal precautions are in place after any surgery that requires a sternal opening. So if they have to crack the chest open, the patient is going to have sternal precautions in response to that to prevent dehiscence of the incision. And so it is very important that you educate your patient on what those sternal precautions are, how to abide by them, and how to modify their functional activity to make sure that they don't pop their chest open. Risk factors for dehiscence include diabetes, pendulous breasts, obesity, and COPD. Those sternal precautions that we want to make sure we're educating patients on are going to be to use a pillow to splint when laughing, coughing, or sneezing, so that way they are bracing that chest and helping hold that sternum together. We're going to avoid isometric exercises because we don't want this patient to Valsalva. We're not going to let them lift, push, or pull objects greater than 10 pounds, and so we need to educate them on what 10 pounds is like and how that's going to apply to their function. There's going to be no performing shoulder flexion past 90 degrees if they have a weight in their hand, so they can reach overhead, like to try to stretch a little bit, but they can't lift anything overhead. We want to avoid scapular retraction past neutral, so we're not going to have them do shoulder blade squeezes because we don't want to pull at that anterior chest wall. We're going to avoid trunk flexion and rotation with supine to sit transfers, so we're going to have to show them how to do that log roll situation to get out of bed with limited use of their upper extremities so that they're not pushing with those arms. That we want to minimize or avoid use of their upper extremities with the sit to stands, especially not having them use their hands on the armrests where they have to reach the arms back behind them, because that's going to put them in a position that opens up that chest, and that's not what we want. And they're also going to have to limit their driving and riding in the front seat of the car because of the risk that the airbag places. Sternal precautions are typically in place for 4 to 8 weeks following an open heart surgery, and that's going to be at the direction of the doctor for clearance on those. We hit on this a little bit, but electrical conduction abnormalities are going to cause ectopic beats, and it can be common to have a few ectopic beats in a normal heart. Um, Sometimes it happens, that your heart skipped a beat is more than just a euphemism, but usually they are transient and they happen during times of stress or after ingesting caffeine or nicotine. And ectopic beats are a beat that originate from a site other than the sinus node. So the sinus node is where your heartbeat is supposed to originate from, and an ectopic beat comes from somewhere other than there. And examples of those can include premature atrial contractions and premature ventricular contractions. So a supraventricular ectopy is supra, so above the ventricle, rapid firing of an ectopic focus that originates in any location above the ventricles. Ventricular ectopy is an ectopic beat that originates in the ventricle. Ventricular tachycardia is when there are 4 more premature ventricular contractions in a row, and so those PVCs are occurring without any atrial contraction. And if you remember back to the EKG of the ventricular tachycardia, we had a large QRS complex, but we didn't have any P wave associated with that. And so 4 more PVCs in a row is considered VTAC, and this is life-threatening. And so we want to be able to monitor for things like that if we have a patient who is on telemetry. Ventricular fibrillation is the quivering of the ventricles due to inadequate electrical stimulation. And we saw that on the EKGs where it wasn't quite as drastic of the QRS complex, but it was still very erratic in the EKG presentation. And this again is one of those malignant arrhythmias. And atrial fibrillation, we looked at that EKG earlier as well, where we have normal QRS complexes, but we have the fibrillating P waves because the atria are acting irregular, and that's quivering of the atria due to inadequate electrical stimulation. And we can also see conduction delays and blocks where we will be missing heartbeats. Ways that these arrhythmias can be addressed is through the implementation of a pacemaker. Common indications for a pacemaker include a heart rate that is too slow, so a patient with bradycardia, a heart rate that fails to increase appropriately with exercise, so it's lacking the sympathetic nervous system stimulation that it needs, or an electrical pathway that is blocked, resulting in an atrioventricular delays or blocks. And that's, again, we talked about the missing QRS complexes on a EKG. Pacemakers have a rate and rhythm sensitivity, and they can override certain arrhythmias. Patients with pacemakers will often have a heart rate max that is not based off of age predicted because it's just the max setting that the pacemaker is set to. And they will typically have a pretty consistent resting heart rate, again, because this is controlled by a machine and not nervous system stimulation. Cardiac rehab following MI. In this context, we're talking about the cardiac rehab that may or may not include a lot of therapists on the team and maybe more exercise physiologist based. And so looking at these phases is specific to that context of cardiac rehab and not specifically cardiac rehab within physical therapy. However, when we look at the indications and timeline for the phases here in a minute, it's going to have some application to what we want to consider for our patient status whenever we are treating them. And so keep those things in mind as we go through this. But cardiac rehab is a multidisciplinary process that may include a physician, a nurse, a physical therapist, an occupational therapist, an exercise physiologist, a nutritionist, and a social work or social service caseworker. It begins in the hospital and continues indefinitely into the maintenance phase. Phase 1 is the inpatient hospital component. Phase 2 is the outpatient exercise training phase. And phase 3 is the maintenance phase. During phase 1, which will depend on the length of the hospital stay, an uncomplicated MI usually spends 3 to 5 days in the hospital. And so that would be an MI that didn't require surgical intervention. The team approach is focused on activity, progress, patient education, hemodynamic and EKG monitoring, medical and pharmacological management. The physical therapy focus is to monitor activity tolerance, prepare the patient for discharge, educate the patient to recognize adverse symptoms with activity, so that dyspnea scale and angina scale, support risk factor modification, provide emotional support, and collaborate with other team members. During phase 1, we are going to ensure vital sign monitoring before, during, and after activity. And these patients being in the acute care side often have EKG monitoring set up to them that's being monitored at the nurse's station. And so that doesn't necessarily fall on the therapist to have to worry about. But it's important to be aware of those vitals need to be tracked and you need to make sure that somebody is on it. And heart rate isn't the only vital that we want to pay attention to. And so are we assessing their O2 sats? Are we assessing their blood pressure? Are we getting all of that information? Intensity should be low level. On the RPE scale, they should be working at fairly light, which is a 9 out of 20 on that 6 to 20 scale. Progression depends on an individual patient response. Level 1 of phase 1, usually in the ICU when the patient is stable 24 hours after admission or after the patient has been stabilized for 24 hours. Their blood work must indicate that the MI has completely stabilized, and so that's where we want to see those troponins have leveled off. And then activity includes working on things like bed mobility, ankle pumps, deep breathing exercises, and using the commode if they are stable enough to get out of bed, and performing limited personal care. So we want to improve their mobility, promote circulation, promote deep breathing, and sorry, someone knocked at my door. But we want to promote deep breathing and obviously providing patient education about all of those things we discussed earlier. Phase 1, level 2, that's where we're going to progress to out of bed activities if the patient is stable. We'll watch for signs of orthostatic hypotension as we progress out of bed because if they've been in bed, especially for 24 or more hours, then their body's response is going to be different to that change in position. And so we want to ensure that we are letting our patient get their feet on the ground, that they are fully stable before we make any transition from seated to standing, that they have no symptoms of lightheadedness, dizziness before we have them take any steps. Once they've reached standing, we are assessing how they feel. If they're reporting any of those symptoms, we are checking vitals as appropriate, returning them to a seated position as needed, but ensuring that we are mindful of the risk of orthostatic hypotension. Our activities are going to include walking to the bedside chair, sitting upright for up to 30 minutes a few times per day, performing lower extremity exercises such as ankle pumps, long arcs, and marching in place. Also, thinking we're wanting to promote muscle activation and all of those things, but it's also about the circulation. And so we're trying to decrease load on the heart by making sure that we get the best return to the heart. And we can't do that if we get venous pooling because we don't have sufficient muscle pumping. So ankle pumps are a great place to start our patient in that phase one, level one, but we need to make sure that we progress the more proximal joint motion as well so that we get the muscle pumping action needed to return blood supply to the heart so that we decrease stress on the recovering heart. And again, we're going to continue to monitor vital signs before, during, and after activity. As the patient continues to progress, we're going to gradually increase their ambulation duration. Usually we use time goals more than distance goals because that's easier for the patient to conceptualize, but we want to make sure that we are thoroughly documenting the distance that they're ambulating because that's going to be more accurate and objective information for the insurance companies to worry about for reimbursement. And so giving patient-oriented direction but documentation towards the payer will help to make sure that all parties are satisfied. They also help translate more easily to a home exercise program if you tell a patient to walk for a certain amount of time versus a certain distance, because conceptualizing distance is just difficult for patients. Therapists, we already talked about, should document the distance in the medical record. You want to provide patient education on coronary artery disease risk factors, activity, and lifestyle modifications to help decrease risk of future heart events or cardiac events, and provide the patient with written education materials. Print things off the internet if you have to, but giving your patient something that they can read later on about lifestyle modifications is going to be a lot easier for them to actually put into place than hearing the instructions from you in a place where they feel like, okay, I should be making this agreement and I should be making this commitment, but they don't have any reminder for follow through at home can be difficult. And so if we want to help support our patients in the best way, giving them those handouts is really the best way to go about that. While we are progressing them, we want to increase the endurance or the activity tolerance capacity that we are pushing them to. And so we're going to continue to use the Borg RPE to monitor their activity levels, and pushing them to shoot towards an 11 to 13 range. We want to maximize their efforts, but we're not going to exceed a 13 on the RPE for our cardiac rehab patients or our pulmonary rehab patients. That is going to be our 11 to 13 is our target range, and we don't want to exceed a 13. Continuing to move on, we're going to gradually increase ambulation frequency and distance. The patient should be comfortable at a leisurely pace, so we don't want to worry about pushing them on speed just quite yet. That's going to be more in the outpatient phase of this. This is about getting them to be functional in their home environment, walking at a pace and distance that is comfortable for what they can handle. Especially if the patient has stairs at home, we want to initiate stairs in at this point. Give them planned rest breaks. Don't shoot for an entire flight of stairs. Be like, okay, we're gonna head out to the hallway and see if you can conquer the stairs between the first floor and the second floor all in one shot. Take them to the therapy stairs and do 4 at a time. Okay, can we do 8 at a time? Progress them gradually. Give them rest breaks. When you do take them to the stairwell to try real stairs, which you should and you will. Bring a chair. Make sure that you have a chair on the landing and plan the rest breaks, because while they might demonstrate the ability to go up and down a flight's worth of stairs in the gym, there's a different psychological component when you take it to a full stairwell. And so that may inherently make the patient feel more exhausted or wiped out from the activity. And so you want to plan appropriately and be safe. Give yourself that precautionary measure. Upper extremity and lower extremity and trunk exercises at a gentle intensity. We want to make sure that we are promoting motion but not overstretching at this phase, especially if the patient has had any kind of surgical intervention with sternal precautions. We need to make sure that we are abiding by sternal precautions first and foremost, and implementing stretching to prevent tightness in surrounding areas but protecting that incision site. Educate the patient on fatigue and planning rests accordingly. Using the money analogy for energy is helpful. So telling them, think of your energy as $1. You can do any activity and spend your energy, but you don't want to ever spend more than 50 cents at a time. You can get money back by resting and building your dollar back up. I think it's a really cheesy example, but patients seem to be able to respond to it on some level. And so, whether that specifically works for you or you have another analogy that you can create to help them understand the process of energy conservation and activity pacing and how we need to group things and still plan rest breaks and coordinate for the long term and planning the whole day and not just the right now. In our HEB provision for ambulation goals, the patient days will be a combination of rest and low-level activity, including ambulation and lower extremity and upper extremity mobility. So we want to, again, educate them on performing their normal activities once they get home, but also how do we incorporate these continued walking and stretching and light strengthening exercises to promote continued gains in their day-to-day activity while we're also incorporating these planned rest breaks. And so educating them on just what their day should look like upon discharge home. Another presentation of cardiac conditions that we need to be mindful of would be heart failure, and heart failure is rather prevalent in North America. The risk of developing heart failure for both sexes at age 40 is 1 in 5, and that risk increases exponentially with age. It's most commonly caused by cardiac muscle dysfunction, but it can also be caused by diseases of any part of the heart, including myocardium, pericardium, endocardium, heart valves, coronary vessels, or metabolic disorders that end up affecting the heart. When we look at right versus left-sided failure, so we've got two different sides of our heart and they can be affected differently in their failure presentation. And right-sided heart failure looks at the right ventricle issue is caused by conditions that increase pulmonary artery pressure. So we want to think about whichever side of the heart is failing, it's going to back up into the system behind that. And so that's why I talked about reviewing the path of blood through the heart is important because that helps you understand the effects of heart failure here. So if my right ventricle is going to increase my, or is going to back up into my pulmonary artery and that have that increased pulmonary artery pressure, it increases the afterload. And so my right ventricle has a greater force that it needs to push, right? Blood is not effectively ejected from the right ventricle and it backs up into the right atrium and into the venous system. So our two hallmark signs of right-sided heart failure are going to be jugular venous distension and peripheral edema because it can't escape the right ventricle because of the increased afterload of the pressure in the pulmonary artery. And so it's hanging out in the right atrium and then into the peripheral body because it can't get into the lungs. The left-sided heart failure is going to be a left ventricle issue, and this results in a decreased cardiac output and backflow of fluid into the lungs, because on the left side, the blood has passed through the lungs for oxygenation before coming to the left ventricle. So our hallmark signs of left-sided heart failure are going to be shortness of breath and cough, because that congestion is sitting in the lungs. With severe left-sided heart failure, we can see a bilateral heart failure or biventricular, where they'll present with signs of both right and left. And so essentially the left-sided heart failure ends up causing a right-sided heart failure that then presents with bilateral symptom presentation. Beyond looking at the difference between the effects to the right side of the heart and the left side of the heart, we can also look at heart failure in the context of systolic failure or dysfunction or diastolic dysfunction. And so systolic dysfunction is characterized by compromised contractile function of the ventricles, which results in a decreased stroke volume, cardiac output, and ejection fraction. So patients with systolic dysfunction usually present with an ejection fraction of less than 40. We compare that with patients with diastolic dysfunction, which is characterized by the inability of the ventricles to relax and refill during the diastolic phase. And this results in a reduced stroke volume and cardiac output, but the ejection fraction may be normal. So the difference that we're looking at between systolic dysfunction and diastolic dysfunction is that with systolic dysfunction, we are going to have a decrease in all three: stroke volume, cardiac output, and ejection fraction. Diastolic dysfunction, we're only going to have a decrease in stroke volume and cardiac output. Ejection fraction should not be affected. Patients with acute heart failure will have activation of the sympathetic nervous system, which increases their heart rate and makes them present as tachycardic. If the heart is in failure and injecting low blood volumes, the blood begins to accumulate in the ventricles and causes congestion. This increase in congestion will increase heart pressures and increase pressure in the pulmonary veins, causing a backup of fluid in the lungs, resulting in pulmonary edema. Kidney function is important to consider in patients with heart failure. Low blood volume pumped out of the heart causes less blood to perfuse the kidneys, which is likely to put the kidneys in failure. So a lot of patients with heart failure will also develop renal failure, and that's part of why it's so important to check our labs looking at those BUN and creatinine levels, because BUN and creatinine are an indicator of kidney function. Patients with hypertension will have too much kidney perfusion, and so that can cause renal damage, and so the kidneys are very closely tied to the heart. We also will talk about the kidneys and how they're tied to the pulmonary system with metabolic acidosis and metabolic alkalosis in the pulmonary lecture, but it's not a common connection that people just make, and so it's important to understand that kidney and renal function is very closely tied to heart and lung function. Hallmark signs of congestive heart failure include fatigue, dyspnea, edema, which can be either pulmonary or peripheral depending on the side of the heart that's involved, or both if it's progressed to a biventricular presentation. Weight gain, and that's going to be 3 pounds in 3 days, is our hallmark sign that we're paying attention to in congestive heart failure, and that's due to the edema. They'll have a 3-pound weight gain in 3 days. We will also hear an S3 heart sound on auscultation, and that's going to be one of our abnormal heart sounds. Remember that S1 and S2 are our normal heart sounds. S3 would be an abnormal heart sound that we can hear on auscultation in patients with CHF. And then renal dysfunction, again, because the kidneys are so closely tied to the heart function. Compensated heart failure is when a patient's symptoms can be relieved by medical intervention. Decompensated heart failure is the presence of new or worsening signs and symptoms of dyspnea, fatigue, or edema. So patients will often go through cycles of compensated versus decompensated depending on how well their medical management is going, and how much fluid they are retaining. And patients who have exacerbations of CHF are said to be in a decompensated state, and it is our responsibility to help progress them from a decompensated state without overly taxing them. Interventions for heart failure, we're going to work on aerobic exercise using the RPE scale. So again, you can use the 0 to 10 scale because that is easier for patients to conceptualize, but the 6 to 20 scale is meant to correlate with heart rate, and so there are clearer parameters about what level to work our patients at using the 6 to 20 scale than there are to the 0 to 10 scale. And so I would encourage you to just familiarize yourself with the 6 to 20 scale and try to understand it in a way that you can apply it to patients and educate them easily, because it does have more clinical relevance. We want to initiate those cardiac patients at the fairly light level, so a 9 out of 20 on that 6 to 20 scale, and progressing them to our target range of 11 to 13, not exceeding a 13 out of 20. We want to terminate activity and provide the patient with a rest break if they exceed that 13 out of 20 on the Borg scale. With strength training, we don't want to use isometrics because of the potential risk of Valsalva, and so isometrics are going to be contraindicated in this population, but we do want to implement light upper extremity and lower extremity resistance exercises. Remember, especially if peripheral edema is a consequence of the heart failure that they are experiencing, the muscle pumping action is going to help promote circulation and blood flow back to the heart, and we need that to help progress the patient from a decompensated to a compensated state. So no isometrics, but do implement light upper and lower extremity resistance exercises, especially for that muscle pumping function. And we want to encourage ventilatory muscle training. This is beneficial for patients with heart failure, especially when they are experiencing pulmonary edema, and so helping to get the inspiratory muscles working correctly is important for their activity tolerance. And sometimes that is training just for understanding the right muscles to use because patients have become reliant on accessory muscles. And we'll talk about this a little bit more in pulmonary rehab as well. But we want to make sure that we encourage diaphragmatic breathing, which helps to reduce accessory muscle breathing use and reduces the work of breathing. And we do that. We can use the tactile cues by having patient place their hand on their diaphragm and telling them to push out into their hand, and then we can use our hand as a tactile cue, and then progressively add a resistance where there's a manual resistance being applied to help increase the strength of the diaphragm. We can also teach patients pursed-lipped breathing, which is shown to help patients with CHF, especially with a pulmonary edema exacerbation with oxygenation levels. And while this has less to do with the prevention of alveolar collapse like it does in patients with COPD, it does increase the time that the oxygen stays in the lungs for the blood to circulate and get oxygenated to improve peripheral oxygenation. We can also teach them chest wall expansion breathing exercises where we would place hands on the lower ribs to provide a tactile cue and then progressively provide manual resistance for strengthening purposes. We'll talk about that a little bit more in pulmonary. Activity pacing and energy conservation is going to be a huge component of cardiac rehabilitation because that is how we can teach the patient to decrease the workload on the heart and successfully train the heart to respond to the body's oxygen demands. Pacing and energy conservation help to reduce workload on the heart, and it's recommended that we use frequent rest before the patient gets tired. And that's why it's so important that we utilize that RPE scale to rate where our patient is working and provide adequate rest breaks so that they can basically refill their reserves to be able to push up to that 11 to 13 range again. We want to educate the patient to engage in activities that require more energy at times of the day when they have the most energy. And so the patient is going to know themselves best as far as whether they're more of a morning person or a night person or where their energy waxes and wanes throughout the day. And so we want to hear that information, get it from them through interview, get it from them through basic conversation, just, making small talk as you work with them and learn things about them, and then use that information to educate them on how to best structure their life to make them safest and efficient. Educate them on planning ahead so that they can, collect things all in one place instead of having to make multiple trips back and forth, or what things that they need to delegate to somebody else because it's not appropriate for them to do. If their mailbox is at the end of their driveway, then cool, let's work on a goal of getting them out to check the mail every day. But if their mailbox is half a mile down the street, then maybe at this juncture somebody else is checking the mail for them, and we need to provide that education and make sure that they're making the best choices. We want to educate them on an alternate or to alternate easy and difficult tasks with rest intervals in between. And so basically using the relative rest concept of therapy and helping them apply that to their life. If you've got a harder task, let's knock that out, give yourself a little rest break, do an easier task before you get on to something hard again where you have a little rest break in between again. But how do we structure those things so that we can maximize efficiency and maximize the patient's ability to rest and be productive during that rest? And then adjust the environment to reduce work, sit when feasible for an activity. So, as we're progressing the standing tolerance and there's somebody who loves to cook, well, are the things that we can sit at the table or the kitchen or the counter, get a stool and chop while we're in a seated position because we're not quite ready for 30 consecutive minutes of standing. How do we make sure that we progress towards that goal, but also while ensuring that the patient is safe in the process? When pharmacological management and physical therapy intervention aren't sufficient to get a patient into a compensated state, then the other medical intervention that might be utilized are things like mechanical assist devices, which are devices that can be used to provide either temporary or permanent support for a failing heart. They're used when cardiac output is insufficient to perfuse the vital organs despite pharmacological support. So essentially, no matter how much training that we've tried to do, no matter how much pharmacological management the doctors have tried to implement, the body still isn't receiving the blood supply it needs, and there are other organs at risk of failing because of that lack of oxygenation. So they'll use intra-aortic balloon pumps, ventricular assist devices, and cardiopulmonary bypass machines. Early progressive mobilization has been shown to improve outcomes in patients with left ventricular assist devices, or LVADs. And so understanding what kind of procedure a patient has had, the intra-aortic balloon pump is going to go into the aorta and help improve pumping of the aorta. Ventricular assist devices are going to help the effectiveness of ventricular contraction to increase blood flow either to the pulmonary system for oxygenation or to the body, depending on where the heart failure is most prevalent. And cardiopulmonary bypass machines are just basically having the machine do the circulating of the blood through the body and having a patient on a more mechanical life support setup. Bypass is utilized for surgery, but if a patient needs to remain on bypass outside of surgery or go on to bypass outside of surgery, it is a life support mechanism at that point. LVADs, they would be able to go and be semi-functional. There's reduced heart rates after the placement of an LVAD, but patients do have positive outcomes, especially when early progressive mobilization is utilized. And so that means physical therapy getting involved early, having the patient get up and walk and not being sedentary in bed. The most important thing to remember with patients who have an LVAD is that they are operating on a battery, and so you need to make sure that you have the battery pack charged before you leave the room, and that you have a backup battery with you so that the patient's battery pack doesn't die and therefore their heart stops pumping. And so being mindful of the patient's demands in regards to a charging station and backup battery needs, and how long you actually have to leave the room with that patient or do whatever activity before they need to have that battery replaced. Those are all things that you may want to talk to the supervising PT before you see that patient, so that way you have a clear picture for your planning purposes for your treatment. Um, the supervising PT may not be able to give you a clear answer, so nursing might be who you need to talk to. It might be the patient themselves, but getting that information will help you accurately and adequately plan your treatment session. Patients who have had a heart transplant may present with the following, including calf cramps due to the immunosuppressant drugs that they are on in order to accept the donated heart, decreased lower extremity strength, obesity due to long-term corticosteroid use due to the needs prior to the heart transplant, osteoporosis and risk of fracture due to those long-term corticosteroid use, and increased risk of developing atherosclerosis in the coronary arteries after the first post-op year. So being able to educate a patient on those risks, but also knowing what to expect out of your patient presentation and how to manage those things is important in a patient that you are treating following heart transplant. We want to be careful with a recovering heart the same way that we would want to be careful following an MI or cabbage. We are going to start them on the lower end of the RPE scale. We're just trying to get the heart going. We're trying to get normal nervous system innervation of the heart from a new nervous system, or I guess the old nervous system, to a new heart. And so we want to be slow but progressive with how we treat our patient. Heart rate is not a reliable determinant of exercise intensity for these patients. Again, because the heart is denervated and the connection to the body's autonomic nervous system is no longer intact. And so our body has to figure out how to respond in all of the other capacities with a denervated heart. And so we need to make sure that we assess things like blood pressure and RPE to ensure that the heart response to exercise is appropriate. And so make sure that you are aware of that treating a patient with or following a heart transplant We are not going to use heart rate as a way to monitor exercise intensity. We will use blood pressure and RPE scale. Other important considerations after a heart transplant include knowing that the patient is going to be on anti-rejection immunosuppressant medications. And so this may or may not mean that they have some form of reverse precautions because they have a weakened immune system and they need to ensure that they don't get sick. And so reverse precautions might be where your patient is masking and you have more isolated treatment sessions within the room instead of going to the gym because, again, trying to limit contact with others. It's also important to understand that cardiac output is 25 to 30% lower than in the normal population. And so heart transplant might have given them a heart that has an improved cardiac output compared to a failing heart that they were working with, but we're never going to achieve the normal population cardiac output in a patient following a heart transplant. And so we need to be mindful of that in our exercise intensity prescriptions. These patients are typically going to have an elevated blood pressure at rest, and they're going to have a greater systolic response to exercise. And so we need to know what is normal. If we see this huge jump in systolic blood pressure, is that within this patient's normal? Is the exercise intensity okay? And do we have a backup objective measure that we can look at to assess that exercise intensity? And so that's why it's important to look at both blood pressure and RPE scale. Their peak VO2 is usually lower, usually 70 to 80% of normal. And so again, that's going to affect overall exercise intensity and what they're going to be able to achieve and how we progress and push them through our therapy interventions. Vagal nerve stimulation to the heart is disrupted, so heart rate at rest is elevated and rises very little when exercise is initiated. With continued exertion, it does continue to rise gradually but slowly, and it has a lower peak. So heart rate max isn't going to be able to be determined by the patient's age. They're going to have a lower heart rate max than the average patient population, and their heart rate response is going to be slower to increase because it already starts at a higher level. The Borg RPE scale should be used for exercise intensity as heart rate is altered. 12 to 13 goal for RPE, 11 to 13 I'll accept as well, but knowing that we don't want to exceed that 13 level. Data collection related to cardiopulmonary patients is a big component of the licensure exam, and so it's important that we are also aware of the tests and measures that we're going to use for heart patients. And so we're going to look at heart rate and rhythm at rest and exercise. And so that means whether we're looking at an EKG strip or we're assessing pulse with our own fingertips, we can assess heart rate and rhythm. We might not be able to see what type of irregular rhythm the patient is presenting if we're assessing pulse, but we can tell whether the beats are coming at a regular interval. Do we feel regular heartbeats, or is there a more sporadic distribution of heartbeats? And that tells us whether there's a regular or irregular rhythm. And those are things that we can document in our patient's exercise response. We want to make sure that we look at respiratory rate and document that as appropriate, especially if dyspnea and shortness of breath are symptoms that our patient demonstrates. We look at blood pressure at rest and with activity because we have to ensure that a patient has adequate response to exercise. We want to look at pulse ox, again, especially if our patient has shortness of breath or dyspnea symptoms that they're presenting with. We want to ensure that they are getting appropriate oxygenation to the peripheral tissues, and so monitoring pulse ox is a way to do that. Utilizing dyspnea ratings, the dyspnea scale, I believe that is the next slide. We'll look at that one. And the angina scale, looking at their breathing patterns. So orthopnea, do they have shortness of breath in recumbent positions compared to when they are seated upright? Do they have paroxysmal nocturnal dyspnea where they get random shortness of breath at night? What kind of irregular breathing patterns might be present, and are you able to see them? Remember, therapists spend the most time with their patients of any healthcare professionals, and so we may pick up on these things in a way that another discipline hasn't. The angina scale, we will look at that, and we want to make sure that we monitor heart auscultations, looking for abnormal S3 and S4 sounds when we listen to the heart. Lung auscultations, we will get into that in pulmonary rehab, but again, if we have a patient with left-sided congestive heart failure, they have pulmonary edema and pulmonary congestion, and so we have effects of the pulmonary system. And so there's a lot of overlap between our cardiopulm patients, and we want to make sure that we have the skill set to address them in the whole context. And so we'll look at lung auscultations to check for edema, and we'll listen for things like crackles when we're listening for that. Jugular vein distension, so do we see a more prominent jugular vein than should be present? And that's indicative of CHF, specifically right-sided CHF. Pitting edema with weight gain, the weight gain of 3 or more pounds in 3 days is what we talked about earlier, suggests CHF. And we're going to look at the different levels of pitting edema as part of your lab, and so reviewing those might be helpful before coming to class, but if you feel confident in them, just know that that's going to be part of the lab activity. Looking at patients' muscle strength. Again, these patients are typically deconditioned from a decreased activity tolerance over time, and so that deconditioning results in strength deficits that can then contribute to postural deficits, balance deficits, increased fall risk, all of these cascading events. And so we need to remember to treat the whole patient, the whole picture within our scope of care. And then maximal inspiratory pressures. Patients with chronic heart failure have weak inspiratory muscles, and so we might look at pulmonary function test measures, and we'll talk about those a little bit more in depth in the pulmonary lecture. But again, understanding that there is a huge overlap between cardiac and pulmonary patients, and interventions assessment wise, there's going to be overlap in how we address them. So this is our angina and dyspnea scale. They're very nice that they both go from 0 to 4, and so there's not two different sets of numbers to memorize, and they're both also both very nice in that we want to stop a patient at 2 out of 4, not let them get to a 3 out of 4. And so for the angina scale, a 0 is going to be no pain, a 1 is going to be mild or barely noticeable, a 2 is going to be moderate, bothersome, a 3 is going to be moderately severe, very uncomfortable. And that's when we're like, okay, stop. We're going to pause, take a break, give yourself a rest. And remember, this is for use in patients with stable angina only. If they have unstable angina, we are not going to do exercises with them because we don't know the cause. And so we can't determine whether or not taking a rest break is going to decrease that chest pain that they're experiencing. And so the application of this scale is for patients with stable angina only. We'd never want to let a patient get to a 4. Again, we're going to stop them, target no more than a 2 out of 4. Same for the dyspnea scale. 0 is no shortness of breath, 1 is light or barely noticeable, 2 is moderate or bothersome, 3 moderately severe or uncomfortable, we're going to stop. 4 most severe or intense dyspnea they've ever experienced. There are other versions of these scales that have specific instructions, and the one that is on your lab sheet will have specific instructions for counting, I believe specifically for the dyspnea scale, and I want you guys to try that with each other in lab because I think it's important to, give yourself conceptualization of what the difference between light, barely noticeable dyspnea is and moderate, bothersome dyspnea is, so that you are able to appropriately educate your patient, and it gives you a concrete marker should you need that when treating a patient. But you are safe to understand the scales in this context. Specific outcome measures that we might look at in patients with heart disease. So for cardiovascular conditioning, we can look at the 2-minute walk test or the 6-minute walk test. And I believe you guys did the 6-minute walk test with Miss Scott during aerobic aerobic exercise. But the 2-minute walk test is just a shortened version of the 6-minute walk test. It has its own standardization and normative values. And so remember, if we are giving any of these objective measures, we want to make sure that we are following the standard setup, the standard instructions, all of those things so that we can compare them to the normative values. But either way, the 2-minute walk is just a shortened version of the 6-minute walk test. That tends to be more appropriate in severely deconditioned patients. The 2-minute step test, again, has its own standardized approach, and instructions and normative values, but is based towards patients who are appropriate for stair training. So this is maybe when we're looking at avoiding that ceiling effect. They've progressed beyond the 2 minute or 6 minute walk test, and so they are a higher level function that would be appropriate for the 2 minute step test or a treadmill stress test. As therapists, we are not likely to perform a whole lot of treadmill stress tests just because of the context and specificity of those protocols. They are not necessarily the most clinically practical to perform versus, look at 2 minute, 6 minute, 2 minute step test or walk test. Those are going to be implemented pretty quickly. And so they're just performed more regularly in the clinic. Balance and fall risk tests, timed up and go and Berg balance are common ones, but we have discussed a lot of different fall risk assessments, and so understanding that depending on what the patient's actual functional level and fall risk level is, which test would be most appropriate. They might be more appropriate for something like the functional gait assessment or the DGI. Quality of life measures, so examples specific to cardiac are going to be the Minnesota Living with Heart Failure questionnaire and the Seattle Angina questionnaire, and those are self-reports the patient would fill out about their quality of life, and typically those are going to be given by the caseworkers in the hospital context and carried on by primary care, but they might be implemented in an outpatient clinic, especially if they have a high cardiac population, as one of the standard self-report measures that are collected with patient data. And so being familiar with them, just recognizing, okay, that's a quality of life measure. And then activity and participation measures. There's the activity measure for post-acute care and mobility measures in post-acute care. FIM no longer exists. It is now the impact spades that we talked about. And one of your groups will present more thoroughly on the impact spades, and then OASIS is specific to home health. But remember that impact spades is meant to be used across all settings, and so it wouldn't surprise me if in the coming years OASIS ended up being phased out. Patient education for heart disease, we want to encourage the patient to understand their activity guidelines. How do we do that? Well, educating them on the RPE scale is probably the easiest way to do that. So patients have Apple Watches and heart rate monitors that can help them monitor their heart rate pretty easily, and we can use that. But as we've learned, a lot of patients can't use heart rate as a reliable measure of exercise intensity, because whether it's the medication that they're on or the nervous system stimulation to the heart, there is an abnormal heart rate response to exercise in patients with cardiac conditions. And so we can teach them to monitor their heart rate. It's not going to be 100% wrong, but it's also not going to be 100% right. And I think RPE is typically easier for patients to conceptualize as far as how to apply that to any activity they're doing, instead of, oh crap, do I have my watch on, or do I have to open up the heart monitoring portion of it, and am I doing things right? Because a lot of times these things are needed to be implemented not just in the context of exercise, but in the context of their normal activity performance. And so RPE just seems to be more globally applicable. We can also teach them symptom recognition and response, and teaching them to rest and the appropriate breathing responses. So whether that's encouraging diaphragmatic breathing because they tend to rely on accessory muscle breathing as they participate in activity, or teaching them pursed lip breathing so that there's greater time for oxygenation of the blood, or teaching them chest wall expansion because of how they utilize accessory muscles, whichever seems to be most appropriate for that patient's needs, but teaching them the appropriate breathing strategies while they take a rest, educating them on placing rest opportunity places throughout their home, so that way, depending on their need level, they're never found in a place where they're just stuck having to recover. Giving them guidance on nutrition, especially we talked about the low sodium in patients with hypertension. Any kind of handouts that you can give on the nutrition and lifestyle issues are typically going to benefit patients more, because while they can hear you while you're with them, does it last? And do they have something that they can review on their own and change? Not only, you're affecting their awareness of the issue, but have we been able to adequately affect their attitude? And can we best affect their attitude by preaching it to them all the time or giving them opportunities to educate themselves. And then making sure that we educate them on their medications, whether they're new medications or old medications that we're discovering the effects of, but how to time those things with therapy or manage those based on medical instruction, but making sure that you help to reinforce that message. Obviously, aerobic exercise is going to be a huge component of intervention in cardiac patients because we need to restore activity tolerance to the best of our abilities to restore their functional abilities. And deconditioning is a result of a need for an increased aerobic capacity. So, aerobic exercise is any continuous activity that involves rhythmic contraction of large muscle groups and increases their rate of aerobic metabolism. And so, what I want you to take from that is that aerobic exercise does not have to be running, jogging, cycling. It does not have to be those traditional things that we think about in healthy population aerobic exercise. We need to remember that we can create aerobic exercise relative to our patient population as long as it is a continuous activity that involves rhythmic contraction of large muscle groups that increases the rate of aerobic metabolism. And so having the rhythmic contraction of large muscle groups is going to increase the rate of aerobic metabolism. I know that all of you are well aware that marches are a way to have rhythmic contraction of large muscle groups to promote aerobic activity, but there are many other ways to promote aerobic activity or an aerobic exercise, especially in the deconditioned population. And so before your practicals over this patient population, I would encourage you to explore all of the different aerobic exercise applications that you can consider and think of and apply to a hypothetical patient so that you have multiple tools in your toolbox for aerobic exercise. Potential benefits include improvements in central hemodynamics, such as increases in cardiac output, heart rate, and stroke volume during exercise, and decreases in cardiac demand at rest. Appropriately selected aerobic exercise can be helpful for patients with all classes of heart failure as long as their heart failure is not decompensated. So remember, we can't push a patient in aerobic exercise when they are in a decompensated state. We have to progress them in a decompensated state to a compensated state before we can implement aerobic exercise. Functional and symptomatic improvements have been reported when training is performed consistently 3 times per week for 3 or more weeks for 20 to 40 minutes per session at an intensity of 40 to 70% of VO2 max as determined by a graded exercise test. So in the clinic, we're not necessarily going to have the opportunity to determine VO2 max, right? We are going to go ahead and utilize the RPE scale. And so that 11 to 13 range is where we have correlated with that 40 to 70% VO2 max. And so our ultimate goal is going to be, trying to get 20 to 30 minutes. I think 20 minutes is the written minimum from your therapy ed book, but our goal is pushing at least 10-minute increments, working up to at least 20-minute increments of continuous activity 3 times a week at that 11 to 13 on the RPE scale. Isometric resistance exercise should be avoided, and we talked about this in the implications for Valsalva, and so we want to avoid isometrics because it increases afterload on the heart due to that Valsalva, and that's not going to help a patient who are trying to decrease the stress on the heart. Moderate resistance training in combination with aerobic exercise may be safe in this population, and so again, as long as they are not having to Valsalva because of the resistance that we are applying, then we want to have movement in motion for the muscle pumping at each of those joints, whether that's lower extremity or upper extremity. And we want to help increase that muscular strength and endurance that was a result of deconditioning because of the cardiac status of these patients. Interval training allows the muscles to work harder than they could with steady state exercise without excessively stressing the cardiovascular system. And so it's an approach that you may want to consider utilizing in this patient population. Um, give them their rest ratios, whether that's a 15, 10, 30 seconds and 60 seconds of activity, however you need to break it up. There's different protocols, and the research isn't really clear on what the best protocol is. It shows an effectiveness of all interval training protocols in this population. And so, you have a little bit of freedom and creativity in clinical decision making that you can utilize specific to your patient's needs to maximize their participation in activity while also giving them the rest that they need. You should gradually progress the intensity by lengthening the exercise period and shortening the rest period so that we're working them towards a steady state exercise. The three most important factors affecting the risk of exercise in patients with heart failure are the patient's age, the intensity of exercise, and the presence of ischemic heart disease. Exercise should be avoided during periods of heart failure decompensation because of the inability of the heart to meet the oxygen demands of the body during exercise when they are in a decompensated state. Contraindications for therapy in the cardiac population, whether, I think this table says for outpatient, but I think that this can apply for our inpatient population as well when we're looking at some of these lab values and vital signs. We want to be sure that we are terminating exercise appropriately and talking to our medical team, whether that's the supervising PT, the nursing team, the doctor, whoever it may be, that needs the information. If a patient's having adverse responses to exercise or starting out at rest in an adverse state, we don't want to worsen it. And so these are contraindications to therapy. Unstable angina, we talked about that. Uncontrolled hypertension, so if they have resting systolic blood pressure greater than 180 or resting diastolic greater than 110, we're not going to exercise. If we see a drop in blood pressure greater than 20 millimeters of mercury on standing and they are orthostatic and we are not able to recover it, then that's a contraindication. If we are able to do some kind of activity that helps recover their blood pressure in a standing position and not put them at risk of fall, then we're safe. But if we see that drop and we can't recover it, then we're going to go ahead and not perform standing activities at the very least. I would say that's a contraindication to standing therapy, not all therapy. Uncompensated heart failure, so it's going to be one of those relative contraindications where we don't want to do aerobic exercise for sure, and we want to be probably limited in our resistance, no more than body weight, so active range of motion, motions of the upper and lower extremities. But there are patients who are in an uncompensated state that we are trying to treat to help get to a compensated state. And so that's going to be one of our relative contraindications. Uncontrolled sinus tachycardia, so starting with a resting heart rate of greater than 120 beats per minute, we're going to say, let's put a hold on that. Significant aortic stenosis, and again, that's going to come from the medical provider, and we aren't going to know what that level of aortic stenosis is without them having done some kind of medical assessment. And so that information will come from the medical provider. Uncontrolled arrhythmias, whether they're atrial or ventricular, AFib is less of a concern because that is one of our benign arrhythmias, but VTAC and VFib for sure. Severe orthopedic conditions that would prohibit exercise. So if they have any other contraindications like a non-weight bearing status, we're not going to implement aerobic exercise through weight bearing through bilateral lower extremities because that would be contraindicated due to their orthopedic condition. Acute systemic illness or fever, third degree AV block without a pacemaker, and so that's something that we would have to be able to identify on EKG, and the medical team would help us be informed on that. Active pericarditis, active pericarditis or myocarditis. So if it's not being treated, then we aren't going to provide physical therapy intervention until they are being medically managed. Acute thrombophlebitis, again, or recent embolism, both of those related to risk for heart attack and risk for stroke. And so until they have either an IVC filter or they've been put on appropriate anticoagulants, they're going to be on hold from therapy. Uncontrolled diabetes, so again, not being able to uh, know how exercise is going to affect their glucose levels and whether they are going to get depleted or have a spike and the adverse events that can happen as a result of that. So uncontrolled diabetes we're going to be careful with, and any other metabolic conditions such as hypokalemia, hyperkalemia, hypovolemia, those electrolyte imbalances that we discussed earlier that can affect uh, cardiac rhythm and cause arrhythmias. Until those are balanced, that patient is going to be on hold. Just comparing the normal response to exercise to a response to exercise in a patient with heart failure so that you can understand how a patient should respond to intervention. So when we look at the normal population, we have cardiac output is increased from 4 to 6 times from resting level to max exercise, and so we have a normal response of an increased cardiac output with exercise. But in a patient with heart failure, there's less than 50% of the increase that's seen in the normal population. And so the body's ability to, or the heart's ability to meet the body's oxygen demands is diminished in a patient with heart failure. We look at heart rate, there's a linear increase with a 2 to 4 time max increase in heart rate from resting in the normal population, but in a patient with heart failure, there's not going to be a linear increase and there's likely going to be a blunted heart rate response. And so that is why heart rate is not typically a reliable indicator of monitoring exercise intensity in patients with cardiac conditions. Stroke volume is going to be increased 20 to 50% in the normal population, but it is decreased at rest in a patient with heart failure and has a peak increase of only 50 to 65 milliliters with exercise compared to the 100 milliliters in the normal population. So that heart rate response and stroke volume response being decreased both contribute to why the cardiac output is only 50% of the increase seen in the normal healthy population. Because remember, cardiac output is equal to heart rate times stroke volume. The cardiac contractility in the normal population is going to have an increased force, but there's not likely to be a change in force of cardiac contractility in a patient with heart failure during exercise. VO2 is going to peak around 30 to 40 milliliters per kilogram per minute in the healthy population, but only 10 to 20 milliliters per kilogram per minute in the patients with heart failure. And so oxygenation is almost a third to half of what it is in the healthy population. Blood pressure is going to see a systolic blood pressure increase with a minimal change in diastolic blood pressure in the healthy population, but in the patients with heart failure, we'll see an increase in both a minimal change in both systolic and diastolic blood pressure. And part of that being that systolic blood pressure tends to start elevated compared to the normal population, and so it doesn't have much room to go up. But we don't see as great of a change in either number of blood pressure in patients with heart failure than we do in patients with uh, out heart failure. And so, again, another reason to remember to implement use of the RPE, because not all of our vital signs are going to be reliable objective measures in monitoring exercise intensity. And then peripheral vascular dilation in the healthy population, vasodilation leads to decreased peripheral resistance. And there's no vasodilation in patients with heart failure, and so there is no decreased peripheral resistance, which in turn increases workload on the heart because of needing to overcome that peripheral resistance for contraction. Some specifics to help guide your intervention application in cardiac patients. The exercise mode obviously is going to include some form of aerobic exercise. This has to be the biggest target, and it's important to understand that we can achieve aerobic conditioning through the performance of our other exercises as well. And so picking exercises that can hit both goals and emphasizing aerobic conditioning while achieving balance needs or lower extremity strength needs or upper extremity strength needs is an important aspect to consider in this population. Brisk walking can elicit an adequate training effect in many patients with heart failure. And so, if we can consider accomplishing gait training with balance training, with aerobic training, just by having the patient go on a walk at what is considered a brisk pace for them, then why not kill three birds with one stone? Jogging is not advised because even slow jogging of 3 miles per hour is only tolerated in patients with a VO2 of at least 20 milliliters per kilogram per minute or greater. And as we looked in the last slide, the average VO2 in a patient with heart failure is only 10 to 20 milliliters per kilogram per minute. And so we don't want to put them in an activity where they're already going to be maxing out their VO2. Cycling should not be in a recumbent or semi-recumbent position, as this increases venous return and pulmonary edema for a patient who is experiencing an acute exacerbation, but they are safe to implement as the patient is demonstrating progress. And we can look at that by monitoring their levels of peripheral edema and seeing how they respond to that. Exercise frequency and duration. Severely compromised patients may require a longer rest interval between exercise sessions with gradual progression. So remember, we're trying to slowly decrease the amount of rest time and make it more continuous activity. Exercise prescription in all patients always includes adequate warm-up and cool-down periods at 25 to 50% of their functional capacity level. Don't just jump them in both feet head first. We want to gradually increase intensity for patients with heart failure. Patients with heart failure can tolerate an initial intensity ranging from 40 to 70% VO2 max. And, we talk about, I think, correlating with RPE is going to be your more clinically relevant indicator. And so we want to start our cardiac patients in those early phases at that 9 out of 20, that very light level, and pushing them to work towards that 11 to 13 goal. Intensity should stay 10 beats per minute lower than where symptoms such as angina or dyspnea occur. So if we're able to identify a consistent heart rate that the patient has this symptom onset, then we're going to set our target heart rate at 10 beats per minute lower than that. We've talked about the RPE scale ad nauseum, so I think you guys have that in your head. And then patients with a low initial exercise capacity will generally make faster initial progress than those who start at a high functional capacity. And so if you think about this logically, it makes sense. If you start lower, it's typically easier to make big strides by comparison because you have a pretty low level to compare to. And so those lower level patients are going to see faster initial progress than your higher level patients. Ultimately, your higher level patients should be able to achieve a higher overall level than your lower level patients, but your rate of progression is going to be slower in higher level patients. I think that is all for cardiac rehab. I know that this was a lot, but the good news is that because there is such overlap between cardiac and pulmonary, a lot of these things we don't have to go over again in pulmonary rehab, and so the next video should be shorter. I've got a couple of supplemental things, but we're going to take our time with cardiopulm and make sure that everybody understands it. So play this at a speed that you need to make sure that it makes sense.